therapist. So I'm going to say that at the very beginning. So I don't have expertise in your field. However, I do have 3 children who play rugby. So we have visited physical therapists on a very regular basis, and even experienced a little bit of the restricted blood flow for our oldest. My oldest son plays Division One rugby at Marion University in Indianapolis, and he is much more fit than I am. So he's a little bit of a bodybuilder. He came home the other day. He said, "Dad, guess how much I deadlifted today?" And I said, "What is deadlifting?" So he explained it, and I said, "I don't know, like 200 pounds." And he said 545 pounds. I was like, that seems like a lot of pounds. I really don't have any frame of reference for it, but I can't imagine walking up to 545 pounds and thinking I'm going to pick that up. Like that would never happen for me, but it's something for him. So we've spent a lot of time with physical therapists, but not my area of expertise. So as Gus said, I'm the director for dignity and spiritual care for Parkview Health, but more importantly to what we're going to talk about today, for the past 10 years, I've led our ethics committee. And I know when you saw ethics on the agenda today, you thought to yourself, thank God we're going to have a conversation about that. That's going to be so exciting. I'm sure it's riveting. That's why you stayed, this long for the presentation, just because it's such an exciting topic for you. I don't guarantee that the presentation will be exciting, but there's going to be a few cases that we're going to talk through that I think will stick with you. Because when you've had, and some of you probably already run into ethical questions in your work, what's right to do, what's the right next step for this patient or in this situation. Those things do stick with you over time. You will, if you haven't had experiences where you felt like there was an ethical conflict for something that was going on with the patient, you will have those experiences in the future. There's not a lot of way to prepare for those things either. Your education is going to prepare you to do the good work of helping people to be rehabbed and be in a better place physically. When we encounter ethical dilemmas, we feel unprepared. So we're going to talk through some principles today. Hopefully some of those principles will sound familiar. That will be the boring part of the presentation. When we're going through bullet points of principles for medical ethics, the interesting parts will be the cases, of course. So we're going to go through a very simple case to start. Then we'll move on to one that's a little bit more complex that actually has is a bit germane to the field that you are a part of. And then the last one is going to be the most complex, and we'll talk through that, and I'll be looking for some of your feedback as to what you think about that case particularly. So let's start with Mike. This is not his real name, and this is just a clip art I got from the internet, so it's depersonalized, not our actual patient that I'm going to talk about, but his scenario does reflect an ethics case that we had at Parkview. So Mike came in on a Saturday. He was pretty out of it. He had an irregular heart rhythm. He was hospitalized, admitted to our Parkview Heart Institute for oversight to see how he would do and see what needed to be done next. So he was being seen, by our cardiology team for a few days. In the end, they recommended that he have an AICD placed to keep his heart in rhythm. But Mike said he did not want to have the AICD placed, even though they were explaining to him how his heart was out of rhythm when he came in. This was causing his symptoms. And so Mike, though, said, I'm not interested in having this procedure. And Mike was ready to leave. He wanted out of the hospital. As many people do, right? Many people want out of the hospital. It's very rare to find someone who says, can I please just stay for a few more days in the hospital? But Mike said, I'm not going to do the procedure. If I'm not going to do the procedure, that means I'd like to go ahead and get on with my life and go home. So the question is, can Mike decline the AICD? Yeah. So why can Mike decline? You can say it however you want to say it. There's lots of ways to say, why can Mike decline the AICD? Right to refuse? Yep. How else could you say it? Yeah, he can make his own choices about his own life. Absolutely. Any other way that you would express this? These are all right on. Yeah, he has autonomy over himself. Is that what you're going to say? I took it right out of your mouth. Yeah, respecting patients' autonomy. Can patients make decisions for themselves? Yeah. Can patients make what we would deem as poor decisions for themselves? Do they make poor decisions for themselves? Yes, of course. Do we make poor decisions for ourselves? Also, yes. Yeah, we make poor decisions. How do I know you make poor decisions for your health? Look at what you're doing right now. You're just sitting here listening to me talk. So this is not a good investment in your health, right? You're not exercising right now. Some of you ate the fruit. Some of you probably have eaten other things that weren't so good for you today. We're allowed to make our own decisions, right? None of us actually prioritize our health 100% of the time. It's just actually physically and logistically not possible. So he has the right to make decisions. He even has the right to make poor decisions. So winner, chicken dinner for patient autonomy. You got what was coming up on the slide next. He's got patient autonomy. This is from the ANA Code of Ethics. Patients can refuse. Patient informedness. I heard someone mention that. Does he understand, comprehend what's going on? So let's complicate it a little bit. Obviously, this is not an ethics consult so far, so we got to complicate it somewhat, even though this is the simplest case that we'll discuss. So what if a doctor documented on Saturday when Mike came into the hospital that Mike lacked capacity to make healthcare decisions, and now it's Tuesday? So instead of saying can he decline or can't he decline, let me change the question just a little bit. What do you think we could do next? If Mike's saying Tuesday, I don't want to have it, but the last documentation about his capacity was Saturday, and a doctor said he did not have capacity, what could you do next? Reassess, yeah. Who would you have reassess? Say again? Yeah, physician, neuropsychologist, and in the hospital it could be any attending or consultative physician. So Indiana state law does require a physician to say whether or not this person has capacity to make their own decisions. So it doesn't have to be the same doc that was there on Saturday. Chances are she or he is not on service anymore anyway. So it could be any doctor that's taking care of Mike right now. So if he lacks capacity, what if his cousin wants to make decisions? Let's think through who makes decisions for a patient when they lack capacity. Is there a scenario that you could think of where that cousin gets to make the decisions? Raise your hand for me, because there's so many of you. I hear people talking to this that I'm looking around for who's talking. What were we saying? I heard you talking. Yeah, his healthcare, and it's possible that cousin could be the healthcare representative. Yeah. Other thoughts about the cousin in this situation? Go ahead. Right. Yeah. So if he's got a form in place that designates the cousin can make decisions. Or if he's unmarried, his parents are either deceased or unavailable, has no adult children, has no siblings, you'd have to kind of go down the line quite a ways before you get to cousin. But it is possible that that cousin could make the decisions. If he has an adult child, obviously going to be, as to your point, going to be higher up on the list of next of kin, and that adult child will make decisions. If he has an appointed healthcare representative, that's going to be the person that makes the decisions. So imagine that Mike is married, and the patient that this represented, he was indeed married, and his wife was at the hospital. So imagine that Mike is married, so he has a spouse, but he also has a form for an appointed healthcare representative that names his college bowling buddy, Doug, as his decision maker. And Mike lacks capacity. And today, on Tuesday, the cardiologist says he needs to have this AICD, and this is what I recommend right now. Who will be signing the consent for surgery? Good old Doug. Going to be signing the consent. Now, it's possible if the nurse calls Doug, he might be like, Mike who? I don't even remember. Yeah, we did this back in the day. Or there might be a really good reason why Doug is that person. In fact, we had a situation one time at the hospital where we had a gentleman come in. It was actually somebody that I knew personally. And before he went to surgery, he wanted to appoint a healthcare representative. Well, he was married, so we kind of assumed it was going to be his wife. And when we got to the room, instead, he wanted to nominate appoint his ex-wife as his healthcare representative. A lot. Now, my next question isn't, is this a good relational idea for him? But is that allowed? Sure, absolutely. You can appoint whoever you'd like to appoint as long as they're willing to serve and able to serve. Doesn't mean it's a good pick by him, but he can do that. And in that situation, amazingly, that's what they all wanted. His current wife said, "I think I would get too emotional if I had to make decisions," and he was incapacitated. And then she said, "But his ex-wife really knows about his wishes and what his value systems are, but she doesn't care nearly as much about him." So she could make the decision with less emotion involved, and so we did appoint the ex-wife as his appointed healthcare representative. If he seems more with it today, reassess. We've already talked through that. So let's imagine he does have capacity today. Now we need to reevaluate, right? With Mike, do you understand the risks? Because maybe we've been, and this was the real scenario that this represents, for 3 days we've been talking to his wife because Mike's out of it. And so she understands, because we've had the conversations with her, how serious this is, why we're recommending the AICD, et cetera, et cetera. So just because he's all of a sudden the decision maker doesn't mean he's informed yet. And so in the real situation, our cardiologist and our nursing team sat down with him to make sure he understands why is this what's recommended. So what if Mike's wife, and this is very similar to the actual scenario this represents, he holds power of attorney, appointed healthcare representative, so to your point earlier, she's got the document in place. She wants him to have the AICD placed. But Mike has capacity today. Who's going to make the decision? Yeah, Mike's going to make the decision. Doesn't mean it's going to be an easy conversation. No, it's not going to be an easy conversation. Especially because for her, she's been making these decisions for the past few days, right? So she's in a place of, I'm the one that makes these decisions, and now all of a sudden hubby is awake and alert, and he's making what she probably deems as a very poor decision. But again, patients are permitted to make poor decisions. Okay, this is the boring part of the presentation. So, but please don't check your phone, because now I'll feel offended because I told you it was boring, and then you're going to be on your phone, during this time or whatever. So at least I gave you a warning that this is not the most interesting part. So a little bit about our ethics committee. The Joint Commission requires that we have a process as a health system to go through ethical dilemmas similar to the one we just shared and the two that I'll share in a moment. So we're the ones that do that. We really have a threefold purpose. One is education. Obviously, that's part of what we're doing here today. Policy making. Prior to COVID, the ethics committee did relatively little with making policies at Parkview. And then the whole world got turned upside down. And we'd ask questions like, how are we going to decide who gets the last ventilator? How are we going to decide who we turn away if we don't have space in our hospital anymore? What do we do when a patient who's so bad with COVID that their lungs are completely shot codes? Do we code? Is it ethical to code, or is it ethical to refuse to code, to do compressions and everything for a patient whose lungs are really done from this sickness? And so I used to say before the pandemic that we don't get too involved in policies, and that's not true anymore because we helped create a lot of the policies during the pandemic. We want to talk about stress, right? Be the committee that is putting things into place that might rule out your own grandparent that's going to come to the hospital at some point in the future. So that was a stressful time. I'm proud of the work that we did. I think like a lot of things in COVID, we look back and we would do things differently now. But at the time, we did the best we could with the information we had at the time. Consultation is then our primary thing. So I just talked about with Mike, that was a consult. The next two will be consults as well. I'm not going to read this whole thing to you, but the ethics committee is a large committee at Parkview. Has a kind of a diverse population on it, so that we're representing a lot of different disciplines. So we have nursing chiming in, we have social work, administration, physicians. Some of our allied health professionals are a part of that team as well. So it's a diverse group. And then there's really not a pecking order to the ethics committee. So a patient could say, hey, I want this to go to the ethics committee. A physician could say that, a nurse could say that, a therapist could say that. Really anybody could ask for that consultation. We do not come in and take over cases at Parkview. We have had times that the nurses wish we would come in and take over a case and just say, this is what's going to happen next. But we're like any other consultative service. We're going to give our consult, and then they proceed from there. All right, so two more bullet point, boring-ish slides, and then we'll get into some two other cases. Some generally accepted principles of medical ethics. These will sound familiar for you. We talked about autonomy already, the decisions that we get to make for ourselves. Beneficence, that we're acting in the patient's best interest. This really comes into play at two times. One, when a patient comes into the hospital and we don't have a decision maker there right then for them, but there's a decision that needs to be made. We're always gonna slide towards beneficence in that case. What's the good that we can do for this patient even though we don't have somebody saying this is what we'd like to have you do in this situation. Non-maleficence, no unnecessary burdens. So this seems obvious, right? Like, why would you want to put an unnecessary burden on a patient, whether it's outpatient or somebody that's hospitalized? Let me ask you this, in your realm of expertise, is it possible that physical therapy or occupational therapy is ever an unnecessary burden for a hospitalized patient, particularly? Why would you say, I see a few of you nodding yes. Or tell me about a scenario maybe where that would be an unnecessary burden. Good. Hmm. Okay. Yeah. So it's a good therapy, but it would be maleficence at that point to do the therapy. Yeah. Any other scenarios or thoughts about how this could be unnecessary? Good. Mm. Yeah. Yeah. Or if maybe the provider or the family is asking for a level of intervention that at the end of life is just inappropriate. Yeah, absolutely. But the one example that I think of a lot of times for this is dialysis. And dialysis is a needed intervention, of course, for a lot of patients. But if that patient's at the end of life, is their time best spent taking them down to dialysis and having that experience? Perhaps not. Is it possible that sometimes CPR is an unnecessary burden for certain patients? That's a hard question, right? What do you think? Is it possible that there's a time that CPR is an unnecessary burden? Maleficence. Yeah, good. Well, yeah, absolutely. That would actually be malpractice at that point, as well as maleficence for sure, 100%. And sometimes we agree with the DNR and sometimes we don't, right? So if we don't agree with it, we might be tempted to try to do a little something, and that would still be maleficence at that point. What about other times that CPR might be unwarranted? Go ahead. Yeah, yeah. Yeah, if this person has cancer all through their body, their organs are shutting down, it's not primarily about their heart, and then we're going to do the violence that is CPR to them, that could be an unnecessary burden at that time. And so that warrants a difficult conversation to your point about the DNR. So we're looking at these other situations that we've just described, and maybe that patient's still a full code. So how do we have that conversation now with them about this would not be ethically appropriate to do CPR for your patient? So we need to transition them over to a DNR status instead of full code. And then justice, equality of care. That if it's the president of the healthcare system in one room and a homeless person in the next room, they should be treated the same way. They should be treated with the same level of care. And then these are our lenses. When we have a case come to the ethics committee or I have somebody call me with an ethics consult, these are the lenses we look through. The first is medical indications. And this might seem sort of obvious, like we always think about what are medical indications for whatever we're doing. However, when we get to the point that it's an ethics consult, everything's kind of gone sideways usually. There's tension, and sometimes medical indications become less clear. So to express it in a clear way, Cassidy, what are your thoughts at this point if you're the attending? Other than yeah, yeah. What's your next step, or what might you try now? Good. Mm, yeah, yeah, good. Absolutely. I think that's a great next step. Other thoughts from the standpoint of the attending? Mm, sometimes family can get through in a way that the care team can't. For sure, great idea. Other thoughts from the attending's perspective before we move on?
I might want to bring in like the hospital's legal counsel and figure out exactly what my responsibilities to the healthcare representative.
Yeah. Yeah, because if you continue down this path and we can't get her surgery, she's going to die. So legal team for sure. About from the sister's perspective, how do you feel if you're the sister getting the phone call the second day saying, yeah, we also didn't do it today because your sister had this lucid moment? Yeah, frustrated. What else might you feel? Yeah, yeah, sure. And that's going to actually play into how this turned out for sure. Other thoughts if you're the sister? Go ahead. Yeah, 100%. Great point. Mm-hmm. Yeah. 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 So what if you're the ortho team? You might be out of ortho teams at this point. You know, you don't have like endless ortho teams. You're going back to the office after the second time around. What are you saying when you're back at the mod having a conversation about this patient? She did it again. Doggone it. Yeah. Do you think you're going to send that third ortho team back? Yeah. Yeah. Right. Yeah. Yeah. Maybe you're starting to question the attending a little bit. Like, really? Is she really? Because she seems fine when she's with us.
I feel like I would need more of like in the case like that where the patient could be delusional or whether it's not. Like, what's the criteria on that so close?
Yeah.
Maybe a little closer at that. I don't know how you would
Yeah.
decipher that.
Let's dive a little deeper when she's back in the room about her capacity. Yeah. Because capacity can wax and wane, right? Like maybe she's talking on the TV in the morning and in the afternoon, she's making a lot of sense. Yeah, absolutely. What if you're working therapy on the rehab unit and you might get this patient after she's had an amputation that in at least 2 lucid moments she said she didn't want to have? How do you think rehab will go? What are your concerns with coming in and doing therapy for her? Good. Yeah. Yeah. Yeah, absolutely. I mean, how are you going to progress towards good goals if she's sometimes delusional and other times pissed that her leg's cut off, right? I mean, that's going to be a complicated recovery process. What else from the rehab standpoint? Yeah, go ahead. Right? Yeah. Right? Yeah. A friend of mine who used to work on the rehab, it says you can't do rehab to somebody. You have to do it with somebody. She's probably not going to be a great willing participant, right? Yeah. Other thoughts from the rehab perspective? Yeah. Yeah. Will it be worth that difficulty in the meantime to get her to a place that maybe she's healthy again? And who knows? Maybe the gangrene is part of why she's delusional, right? So maybe once that's addressed, maybe she'll be more with it. So there's that side of things, right? Other thoughts from the rehab side? Hmm. Yeah. Yeah. Mm-hmm. Yeah. And you know from your work that the fact that the sister is the primary support person, but she's out of state, she's only reachable by phone, is going to make things a little more complicated for you. So being that supportive presence is going to be even more meaningful for her because maybe she doesn't have someone physically present with her except for when the sister can visit. Yeah, for sure. What if you're the patient? This might be a little harder to put yourself in the patient's shoes, and so shoes is probably a bad expression for a possible amputee. Um, put yourself in her situation. Let's go with that. How would you feel if you were the patient when you're lucid? A little harder to think about, but can you think of maybe what she's feeling when she's lucid? Yeah, 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 absolutely. She's scared. What else? Yeah, she's there's obviously something going on beneath the surface there.
I have a question.
Sure.
Was that like the only, or were those the only recent moments that she had since she had been in the hospital?
They were the most lucid moments she'd had since she'd been in hospital. So there was a little bit of back and forth, but generally, and I think and we'd had psych consult, I think twice, and then attendings also document that they thought generally she didn't have capacity. So yeah, it's a slippery thing.
Also, like, she might be a little confused on what was actually like psychologically going on. She didn't actually know she was being released.
Yeah.
So in those moments, she might.
Hmm. How about this? Does it impact you from the patient side that this happened twice instead of just once? What does that mean? Do you think that she was able to say that twice? Yeah, she's expressing a consistent value, even if she's not very with it most of the time. When she seems to come to, she said the same thing twice in a very similar way both times, and actually expressed understanding that if she didn't have the amputation, that it might cost her life. So, um, looking at that consistency of value. This can also be used if a patient's just unconscious, not able to express things, but we knew, and maybe we don't have any documents saying what they would want at in that situation, but we can look back and see their consistent values over time. So decision maker and autonomy. This is a place, so the principles of ethics only get us so far. I walked you through those and they sounded great when I walked you through the principles, right? Like, oh, this will solve all of our problems. Actually, they cause a lot of problems because here we have a question about legal decision maker. That's the sister. But what about patient autonomy? So they're actually in conflict with one another. So the legal standpoint and the ethical principle are actually in conflict with one another in this situation. Beneficence, what is good to do for this patient? It would be good for her to live, is generally what we believe. Is that always true? It's not always true. It's usually true, not always true. So we believe generally it'd be good for her to live, but perhaps it would be okay for us to think about her preferences. Maybe her preference would be to die with both legs than to live with one. We might not agree with that, but she's the one that gets to think about her own quality of life, especially if she has capacity. And if she really doesn't want it, if she's able to express that consistent wish, and we amputate her leg, we have probably participated in maleficence, right? We've done something to her that's an unnecessary burden in her situation. So these don't really clear up the situation for us. So in the end, the consistency of her request mattered to us. The fact that she'd said the same thing on two different occasions in the same way, expressing that she understood what was going on. And then we considered how difficult it would be for therapists once she landed in the rehab unit. But we also considered how difficult it would be for her once she landed there. If she really, in her heart of hearts, doesn't want to have this foot cut off and she really would rather die than have this procedure done, then when she lands there, her value system will not have changed, probably. Even likely if she regains capacity and she's doing well cognitively, she's probably still going to have those thoughts and those feelings, and then she's going to be aggressive. Maybe she doesn't want to do it, that sort of thing. And so probably we're thinking about maleficence there if we proceed. So our wonderful physician, Dr. Shukla, made a call to the sister and took a different approach, and he said, "We recognize you're the legal decision maker. We recognize that you get to sign off on the consent for the amputation or the declination. We also realize that medical indications would say she probably ought to have this foot amputated. However, I think your sister's trying to tell us something." So back to your point of like, I would take it as a sign. We did. We think your sister is communicating from who she really is as a person, even though we've documented that she doesn't have capacity to make her own decisions. We think she's trying to communicate to us. And so at that point, and that was reconnect, then having a good relationship and conversation with the sister, where she was able to say, "I get it. I'm going to back off. I'm not going to push for the amputation anymore." So her sister did not have the amputation. The patient did not have the amputation. She went to, instead of going to rehab, she went to supportive care on hospice, and she later died. And there was never an indication while she was in hospice that she regretted that decision, like you would regret the decision of dropping your phone. I mean, like that. But she never seemed to regret that. She seemed to be embracing of that reality. So in the end, it came down to two things that I didn't list as principles of ethics or lenses of what we view, how we view these cases. It came down to dignity for her, and it came down to practicality. How's it going to go trying to do rehab for a patient like this? Thoughts before we go on to the most complex case? I think it's a good possibility you'll remember this story, and then you'll definitely remember the next one.
I wanted to ask if depression or suicide
Hmm.
indications affect autonomy.
If depression or suicide indications affect autonomy. Hmm.
So history of long-term depression
Yeah.
or something cognitive.
Yeah. The short answer would be no. So even a patient who's schizophrenic or has a significant, mental health diagnosis doesn't necessarily mean that they can't make their own healthcare decisions. Um, in fact, you'll see some of that played out in this next case we're going to talk through. I've never seen depression or even really significant clinical long-term depression lead a doctor to say they can't make their own decisions. Um, Obviously a patient with advanced Alzheimer's or dementia, we're gonna have to look to somebody else for a decision maker. We really view it on a continuum. There's not very few automatics with mental health diagnoses. Am I answering the question you're asking? And it can actually. Ooh, nope, I'm not gonna wander into that. So, well, okay, You guys are all smart and mature, so I didn't understand half of what the student presentations were about. So that tells me how smart you are. So, um, if you have a patient come in after a suicide attempt, does that say something about their patient preferences? Perhaps. Do we still have a duty to try to save a life when they come into the ER? Of course, of course, of course, 100% of the time. But as that patient regains, where they're going to live, um, can it mean something that they at one point in time decided they didn't want to live? It could. Doesn't necessarily. And of course, in the state of Indiana, we're not going to do any kind of physician-assisted suicide or anything like that. Um, but it could. It could mean something to consider that they were at that point, at least somewhat recently. It doesn't mean you're not going to do everything to save them and help them lead a healthy lifestyle. But what what decisions we've made and what lives we've led up to that point do have a bearing on what we would choose in more complicated medical situations. So I wandered in a little bit to your suicide question there because it is a good question. All right. So this was actually my first ethics consult, and it's still one that sticks with me more than I think just about any other than except with one exception, sticks with me more than any other ethics consult I've had. So I had just started leading the ethics committee. I was scared to death after this that they were all going to look like this consult. Thank God there was a lot that looked like Mike instead of looking like this consult. But I got a call on a Monday from an outpatient OBGYN office. And that's not usually, now I know that's not usually where ethics consults come from, an outpatient OBGYN office, but I didn't know much at the time. And so the nurse calling from the outpatient office said, we have an ethics consult. The doctor knows that he's going to need your input about this. So, okay, great. She said, can I fax over some paperwork to you? This tells you a little bit about how long ago it was. She's going to fax medical records over to me. It was quite some time ago. So, like an idiot, I said, sure, this is my fax number. And so I went to the fax machine a little bit later, and there's a stack of paperwork like this. Now, you've probably already sniffed out that I'm not a clinical person. I don't have clinical training. You've figured that out with my failure to pronounce certain things correctly, probably at some point in time. But so, as a non-clinical person, now I've been doing it for 10 years, around healthcare. I understand some more words than I did at that point. But as a non-clinical, relatively new person to the ethics committee, I've got a stack of paperwork from this girl's medical record that's this deep. And so I started flipping through it, hoping to God that, like if you kind of halfway understand a language, if you listen for long enough, eventually you can kind of figure out what's going on. So I'm hoping that clicks in at some point. But what I figured out as I started going through this paperwork is we had a 21-year-old female patient, and her mother had requested that she have a hysterectomy. This is a Monday, and surgery was scheduled already for Thursday of that week. If you were me, would you be okay with surgery going ahead on Thursday, knowing what you know so far? Why not? Say a little louder. Everybody's saying good things, but I hear it all at the same time. So medical indication, yeah. Why? Absolutely. Go ahead.
Why is the mother making a request for an adult?
Yep, absolutely. She's not just 18, she's 21. Anything else so far? Is this disturbing, what you've seen so far? Yeah, that's the way I felt too. As I continued to go through the paperwork, discovered that this patient has Down syndrome. Does that change your thoughts about whether or not surgery could go ahead on Thursday? Yeah. Similar to the question you asked about mental health diagnosis, or this, in this case, a genetic diagnosis, there's a continuum there, right? Other thoughts about this being a Down syndrome patient changes your thoughts or doesn't change your thoughts? So as I continued through the document, I found a 6-page single-space letter from mom that she had addressed to the chairperson of the ethics committee. Does anybody have a very persistent mother in their lives? This patient had a very persistent mother in her life, and so she had written this letter to me, not knowing my name yet. Uh, that gives you a foreshadowing of the rest of the story, but not knowing who I was, but addressing this to me. In this document, she talked about how she was concerned that she didn't want her daughter to become pregnant. She was taking care of her daughter. She didn't want to, have to take care of a grandchild as well, and that her daughter suffered from long cycles that were sort of out of control. Ready for surgery to go ahead on Thursday? I see some vigorous head shaking. No, why not? Megan? Yeah, we're still thinking about medical indications a little bit and other options. Yeah. What else? Is there anything else that still is bugging you about this? Good.
Yeah, patient consent.
Yeah, patient perspective. Just what does she think about it? Go ahead. Yep, absolutely. This is a long-term thing. Yeah. Mm-mm. She had never been pregnant and was not pregnant. Was true. So I called the operator at Riley Health and I said, I need to talk to the chairperson of the ethics committee. So I basically did the same thing mom did to get a hold of me. I did it to Lucia Vogel at IU Health in the Riley Children's Hospital. Got her on the phone, explained some of the basics of the scenario, and said, this is what mom said you guys would do it. What do you think? Is the threat, legitimate that she would just go someplace else? And after some questions, Lucia said, "Well, obviously I don't know all the details, but I think it's likely that we would provide that hysterectomy." Thank you. It doesn't make the decision for us, but gives me just a little bit more context in that situation. And now we come to the important question that you've asked several times: why a hysterectomy? A hysterectomy is a once-for-all sort of surgery. You can't go back. Profound impact on the patient, etc. So for this, we did look through the documentation. So the doctor had actually been treating this patient since she was 14. Had put her on the pill, and she was very good at non-compliance with the pill, highly skilled, uh, keeping it under her tongue, spitting it out, letting mom think that she had taken it, and then she'd find it on the floor or the counter later. They tried a few other interventions. There are some because of her genetic condition with Down syndrome. There were some that the manufacturer of whatever that lesser intervention would say was not recommended for her. So unfortunately, I had to skip some of the lesser things. Because I'm not clinical, I'm not qualified to explain all the details of why some of the lesser things were not warranted for her. But the conversation that we had then on Wednesday with 100% attendance of the ethics committee, because this was a very intense sort of case, and with the OBGYN in the room to be able to talk through the things that they had done, look at the record, et cetera. The question came down to, do we do hysterectomy or do we do ablation for her? So an ablation is a lesser surgery, of course. Hysterectomy is the end of the line. That's the most invasive that you could possibly do. The OBGYN's professional opinion at that point and some other clinicians in the room agreed that because of her age at only 21, that ablation might be a multiple. She might have to have that many times over the course of her childbearing years. And so then it felt like a lesser surgery over, maybe 6 times over the course of her childbearing years, sort of felt on the same level with the hysterectomy. And so it sort of felt like a 6 of one, half a dozen of another sort of situation at that point. So before I tell you what we decided, and you're like, just go on with it, tell us what you decided. So we got to that point. But before we get to that point, does her voice matter in this situation? She doesn't get to be the decision maker. Court has decided that she doesn't get to sign any documents, making any decisions about herself for the rest of her life, unless she can appeal it herself at some point in the future, which she's probably not going to be able to do. So does her voice even come into play or matter here? And if you say yes or no, you have to say why. So that after you said yes. Yeah. Mm. Yeah. Yeah. Anyone think not exactly? Her voice doesn't exactly matter. Yeah. Yeah. Legally, because she's not going to sign the consents, right? Mm-hmm. Yeah. Yeah. Other thoughts? Her voice matter or not? So your two answers are both obviously 100% right. Legally, she's not going to get to sign the consents, but she's a human being. And that fact often gets lost in medicine, that this is a person we're working with. This is not in the end, is not a case, is not just a patient, but it's a human being. And so, come to find out, and it had been documented on 3 different occasions, this OBGYN had talked with this patient, with mom, of course, there, and said, what do you think about, when you're bleeding and you can't be at the day program? And she expressed disappointment. She could speak, she was verbal, and very social. And so she was really not happy about not being able to go to the day program. But then when he asked her about, what do you think about having a baby someday? Or what do you think about having to have surgery, going to the hospital, and having to stay for a day or two? She was not able to express any meaningful opinion about that. She would change the conversation to what she ate for lunch, or the weather outside, or her puppy at home, things that were very socially engaging, but she didn't have the depth of understanding to voice an opinion one way or the other about pregnancy, complex things like pregnancy or surgery. So, so to both of your points, it was important to engage her to get her voice because she's a human being, even though in the end, legally, she's not going to be that decision maker. So our resolution, would you like to hear how we resolved the situation? Like, yeah, just get to it. It's 4 minutes after noon, and you've been talking about this case for forever. So we don't always have a vote for the ethics committee, but we did in this case, and unanimously approved or recommended that we go ahead with the surgery in this case. However, we took a second vote, one that I'm very proud of. I didn't initiate; one of my colleagues did, to say that this case and our resolution of this case would set no precedent for any other case at Parkview in the future. Meaning that we would have to, obviously the details I went through with you today are just some of what we went through in that case, that we would need to take all of those steps the next time there was a situation that bore any similarities to this one. So we had to work through all the details in this case. We would need to do that again next time. That's all the content I have. I know this is sort of a provocative last case. Questions, thoughts, complaints?
What did the timeline look like for that decision-making process? Was it like prior to the original surgery date, or did you guys?
Yeah, so we were able. She did actually have surgery, so that's the other part of it. Is Mom had talked about how social she was and everything. So she had surgery on Thursday, and I actually went up to see her afterwards, and she was very warm and sunny even after surgery. And her dad was in the room. She told me that her mom was down getting her lunch in the cafeteria, and so I just kind of shook her dad's hand. He, like, I introduced myself as the chairperson of the ethics committee, so he understood, but we didn't need to have a conversation about it there in front of her. And she said, my mom's down in the cafeteria getting me a grilled cheese sandwich. And I said, that's great. And she said, have you had the grilled cheese in the cafeteria? I was like, caught. No, I've never had the grilled cheese. My daughter has. I've not. She goes, you need to try the grilled cheese sandwich in the cafeteria. Um, I, I've shared this story because I think it shed so much light on ethics and considerations for years. I actually went 5 years without trying the grilled cheese sandwich in the cafeteria. And one day I went down, I thought, I'm going to give it a try, the grilled cheese sandwich. Not that great, in my opinion, but I'm glad she was enjoying it, for sure. So got back to the office, and I'll cap it with this because we're already over time. Got back to the office, my phone rang later that day. It was Lucia Vogel calling from IU Riley. And she said, we talked about what you called me about on Monday. We talked about it during our ethics committee today. We realized we've never had a case like yours. And we're curious how it resolved. If you can tell me anything so we can learn from what Parkview did so that when we have a case, again, not that would set a precedent for what they would do, but they would have some learning for what they would experience. So it was a neat opportunity to do right by this patient, to do right by this mom, even though I had some negative thoughts about her at the beginning of the process, but also to help sort of our region learn how do you go through a process like this. Other questions, thoughts before we conclude? Yeah, guys. Yeah, that. So now we're going to begin my burnout presentation, which will last another hour. Yeah, it's a great question. That we can't talk enough right now about self-care and healthcare in every way. So yeah, these for me, my role really isn't decisions in these processes. It's more to ask questions, and you can kind of tell that from the way I described it. That's really my only superpower as I help with the ethics committee is sometimes is ignorance actually, like help me understand, these things, and then when we talk through them. The burnout for me comes more with the other team I lead, which are our chaplain team, which during the pandemic responded to 5,563 patient deaths. Um, that one's heavier than the ethics for me. But yeah, self-care and then I just decided I would go ahead and totally burn out and have a mental health crisis last fall. That was very helpful, actually. So yeah, that's the if you want an honest answer, there you go. The reason why I didn't lead with that at the beginning, I guess, right? Other questions, thoughts? Well, these guys know how to get a hold of me. If some of this has struck a chord with you today, and you want to talk more about it, I'd be happy to do so. Back over.